Welcome, everybody. I'm Mark Zuckerman, president of the Century Foundation. For those of you who are not familiar with TCF, we're a progressive independent think tank that drives policy change to make people's lives better. We pursue economic, racial, and gender equity in education, healthcare, and at work. In recent years, our experts have been at the forefront of efforts to defend the Affordable Care Act. And now our work focuses on ways to expand affordable coverage to all Americans and close the healthcare gaps that are facing low-income communities and people of color. At TCF, we are committed to looking at health policy from a multidisciplinary lens and with an eye towards equity. At a time when healthcare of tens of millions of people and reproductive rights of millions more are under a siege, this type of deep intersectional approach to the work is needed more than ever. That's why we're so excited to welcome you to today's event with our remarkable Director of Healthcare Reform and Senior Policy Fellow at the Century Foundation, Jamila Taylor. We're also very pleased to have New Jersey's first Lady Tammy Snyder Murphy and Congressman Lauren Underwood and a very distinguished panel who's going to discuss today's topic. I want to give special thanks to the Commonwealth Fund, who has been a tremendous partner in this work with us. With that, it's my pleasure to introduce Dr. Laurie Zephyrin, Vice President of Healthcare Delivery System Reform at the Commonwealth Fund. Thank you for joining us.
Great. Thank you. Thank you so much, Mark. And really excited about this panel today. I'm Laurie Zephyrin, Vice President of Healthcare Delivery System Reform at the Commonwealth Fund, an OBGYN and a mom. Our research and grant making at the Commonwealth Fund focuses on promoting a high-performance health system that centers health equity and addresses structural racism. This conversation today regarding closing the Medicaid coverage gap for moms will highlight the importance of comprehensive health coverage after birth. We know the importance of insurance coverage and access to health care, and it's a key step, not the only step, but a key step to eliminating disparities. Imagine if you just gave birth and your insurance coverage expires in 60 days. We know that moms need support even up to a year after birth when risks to their health and well-being persist. This is even more apparent for Black moms who experience higher morbidity and mortality before, during, and after birth. We know that moms require mental health and social support after birth, and there's important work on the fourth trimester of care that already indicates key delivery system models. Policies matter and can drive system change. In our current context, this is really an important time for this conversation. Additionally, several states are exploring this as well as their exciting legislative efforts addressing this as part of a comprehensive set of actions to promote policy change that can ultimately drive system change. So now to kick this off, please welcome our keynote speaker, First Lady of New Jersey, Tammy Murphy.
Good afternoon, everyone, and thank you so much for that introduction, Laurie. I am thrilled to be a part of today's program and so appreciative of your leadership at the Commonwealth Fund. I also have to thank the Century Foundation and especially Dr. Jamila Taylor, who will be speaking in just a few minutes, for the invitation to be here, as well as their partnership on the issue of maternal and infant health. A week ago, through Nurture NJ, our administration's initiative to combat New Jersey's maternal and infant health crisis, we held our third annual Black Maternal and Infant Health Leadership Summit. At that virtual event, we welcomed my husband and our governor, Phil Murphy, Lieutenant Governor Sheila Oliver, Senator Cory Booker, Congresswoman Bonnie Watson-Coleman, and we had over 250 stakeholders who actively participated for over 5 hours in small group discussions to provide feedback on our New Jersey maternal and infant health statewide strategic plan, which we are excited to release in January of next year. In this afternoon, I'm here continuing this important discussion with you all, and later this evening, I will be attending a New Jersey NAACP event on Black maternal and infant mortality prevention. The number of maternal and infant health discussions going on across our state and country shows that our mission to save the lives of all mothers and babies has begun to gain momentum. And this momentum is really critical because, make no mistake, we are literally in a crisis. New Jersey is currently ranked 47th in the nation for maternal deaths. A Black mother in New Jersey is 7 times more likely than a white mother to die from maternity-related complications. A Black baby is 3 times more likely than a white baby to die before his or her first birthday. This is one of the widest racial disparities in the entire nation. These statistics are shocking and shameful. New Jersey and the entire country must continue to work to repair the centuries of embedded institutional discrimination and racism that have led to these disparities. Nothing short of transformational change is needed in the many systems that have historically failed our mothers and our babies. In fact, that is one of the most important pieces that I've taken away from learning about both the contributors to our crisis and its solutions. They are incredibly complex. Therefore, it's going to take collaboration and cooperation across sectors, industries, and agencies to really fully resolve this problem. Further, as all of you well know, the causes and contributors to poor maternal health outcomes do not end on the day of delivery. This is why, among many other of Nurture NJ's initiatives, we are working to extend Medicaid coverage for 180 days postpartum. This has the potential to improve the lives of thousands of families. In New Jersey, we have several cities that have high rates of Black maternal and infant mortality, and a large percentage of their female population are on Medicaid. 62% of Trenton and Camden's populations are on Medicaid. And in 2018, there were at least 1,200 births in each city. Extending coverage means improving the health outcomes of a significant number of those births for both mom and baby. Not only does the extension provide some financial and mental relief, it allows for continuous care so providers are able to identify and treat any issues that may come up after delivery. This matters because 70% of pregnancy-related deaths occur within the first year after childbirth. Additionally, between 13 and 19% of all postpartum women experience depression, and low-income mothers of color experience depression at a higher rate. Plain and simple, New Jersey's mothers need support before, during, and after pregnancy and delivery. And that support will come in a multitude of ways. It will come from expanded access to resources, improved pre- and postnatal care, implicit bias and anti-racism training for our medical professionals, and it will come from the persistent advocacy of elected leaders like the incredible Congresswoman Lauren Underwood. As the primary sponsor of the Black Maternal Health Momnibus Bill, which is also sponsored by our amazing Vice President-elect Kamala Harris and my dear friend, New Jersey's Congresswoman Bonnie Watson-Coleman, Congressman Underwood is a powerful voice on the Black maternal and infant health crisis. She's also co-chair and co-founder of the Black Maternal Health Caucus, leading the effort to elevate the Black maternal health crisis within Congress and advancing policy solutions to improve maternal health outcomes and end disparities. And on top of all that, she's a registered nurse, bringing her medical expertise to every policy decision. Congresswoman, thank you so much for being here and for all you do on behalf of our nation's mothers and babies.
Well, thank you, First Lady Murphy, for all of your work. The incredible leadership in New Jersey has been remarkable to watch. I'm so excited to have you as a tremendous partner in our country. And I know that your efforts, our collaborative work will be successful in saving lives. Hi, everybody. Thank you for having me. I'd like to also thank the Century Foundation and the Commonwealth Fund for hosting today's event. And I'd especially like to thank Dr. Jamila Taylor for her leadership. Jamila, thank you for your important research in the urgent topic of postpartum Medicaid coverage. And thank you for your ongoing work to achieve true maternal health equity. You have been an incredible partner for the Black Maternal Health Caucus ever since its founding, and I am so grateful for all that you do. Dr. Taylor's new paper on the Medicaid postpartum coverage gap is timely. As the 116th Congress winds to a close, we have a real opportunity to take a significant step forward on this policy. And we cannot have a conversation about maternal health outcomes in the United States and racial and ethnic health disparities without talking about Medicaid. Medicaid covers 43% of births in the United States and more than 65% of Black births. So any policy that we discuss related to Medicaid coverage for pregnant people will have significant impacts across the country. Expanding postpartum Medicaid coverage is the single best thing that we can do to save moms' lives and tackle the glaring disparities that we see. Right now, the majority of pregnancy-related deaths happen after the day of delivery, and nearly a quarter of pregnancy-related deaths happen more than 6 weeks postpartum. By extending Medicaid coverage from 60 days after delivery to 1 year, moms will be able to receive the care that they need and deserve for the full postpartum period. Dr. Taylor's research shines additional light on why this coverage expansion would be so important, including in my state of Illinois. By providing continuous coverage for the full year after delivery, new moms will be able to access contraception, mental health care, doula services, and treatments for chronic health conditions. That's why I'm excited about the progress that we've made in the past year to pass legislation led by Congresswoman Robin Kelly to extend postpartum Medicaid coverage to a full year after the end of a pregnancy. In September, the House unanimously passed the Helping Moms Act, which would allow states to extend coverage for the full year-long postpartum period. In the remaining months of this Congress, we are working hard to get that legislation across the finish line and signed into law. And we will not stop fighting until year-long postpartum Medicaid coverage is a reality for every mom in every state. But we can't solve this crisis through coverage alone. We will need a comprehensive and targeted set of policies to address the key drivers of our nation's maternal health crisis and the persistent disparities in outcomes. That's why in March of this year, I introduced the Black Maternal Health Momnibus Act with Vice President-elect Kamala Harris and Congresswoman Alma Adams. The Momnibus includes 9 bills to comprehensively address every dimension of the Black maternal health crisis in the United States, from investing in community-based organizations to growing and diversifying the perinatal workforce and addressing social determinants of health. These bills have become even more important in the context of COVID-19. For example, the Moms Matter Act in the Momnibus specifically focuses on maternal mental health and substance use disorders. The Centers for Disease Control and Prevention has reported that during this pandemic, Americans are experiencing significantly higher rates of adverse mental health outcomes, increased substance use, and elevated levels of suicide ideation. And Black and Hispanic Americans have been disproportionately impacted. That's why we need the resources of the Moms Matter Act to ensure people have the mental and behavioral health treatments and support that they need in the prenatal and postpartum periods. These policies and the others included in the Momnibus will continue to be priorities for the Black Maternal Health Caucus in the coming weeks and months. We're going to count on the continued support of advocates across the country to push these policies forward and to achieve birth equity in the United States. I am so grateful for the important work that Dr. Taylor has led in this space, and it's my honor to introduce her at this time.
Thank you so much, Representative Underwood, First Lady Murphy, Mark, Lori, for your brilliant introductory remarks. And so right now I'm going to present on our research that many of our speakers have mentioned today. Give me 1 second to share my screen and we'll get started. Okay. So the research that I'm going to present today, as you all know, is focused on closing the Medicaid coverage gap for mothers. I'm going to start with an overview of the problem, then talk through our approach to the research, share some facts about Medicaid and pregnancy, and then end with our key findings, lessons learned, and our policy recommendations. The United States is in the midst of a maternal health crisis, a crisis that falls hardest on Black women and their families. Black women are most likely to die due to pregnancy-related causes. They're also most likely to experience serious illness and injury from pregnancy complications, and they make up a disproportionate share of Medicaid enrollees. We know that most maternal deaths occur at delivery and up to a year after giving birth. Despite this, women lose their Medicaid coverage just 60 days after giving birth. For this project, we examined the coverage loss at 60 days by conducting qualitative analyses of public policy efforts in 3 states: Illinois, New Jersey, and South Carolina. We conducted extensive document review, analysis of existing literature, and interviews with subject matter experts and key stakeholders, including state Medicaid directors, physicians, researchers, local elected officials, and mothers who were covered by Medicaid for the births of their children. Throughout this project, we have centered the experiences of mothers of color first and foremost. This project was funded by the Commonwealth Fund. Medicaid covers about 43% of births nationally. Under the program, pregnancy-related benefits include prenatal care, labor and delivery, and postpartum care for 60 days. It covers pregnant and postpartum women, generally at around 133% of the federal poverty line. Now, I will mention that this FPL can vary based on the state that a woman lives in. You'll see more about this later in the presentation. So we chose to focus on Illinois, South Carolina, and New Jersey, partially because of the geographic mix, but also because these are 3 states that have submitted Section 1115 waivers in order to test their approaches with the federal government to extending the postpartum coverage. Illinois and New Jersey currently have applications that are pending with the federal government, whereas South Carolina's proposal was denied. Illinois and New Jersey are also Medicaid expansion states, meaning that they offer a generous benefits package under the Medicaid program for the broader population, whereas South Carolina has not expanded Medicaid. So here we show maternal health outcomes across the 3 states. The Black-white disparity in all 3 states is consistent with what we see at the national level, which is a difference of 3 to 4 times the rate of maternal mortality for Black women when compared to white women. Illinois and New Jersey are funding births through Medicaid at about 40%, whereas South Carolina covers a much higher share at 64%. New Jersey and South Carolina, their FPL is 199%, whereas Illinois is 213%. So what we found coming out of this project is that Medicaid coverage loss for mothers leads to disruptions in coverage and insurance churn. Insurance churn happens when a person moves back and forth between having insurance and not having insurance, or between different healthcare plans. It also leads to a lack of continuity of care. Timely and continuous care can help identify and manage and treat health conditions, which is not only essential for mom's health, but also the health of the baby. Coverage loss leads to a loss of care coordination. This is particularly important for high-need moms. It can be hard for them to manage all of their different needs without the help of care coordinators, whose services are paid for by health plans. Coverage loss also leads to a lack of contraception and mental health services. It leads to mismanagement of chronic health conditions, including heart disease, diabetes, and high blood pressure. It also leads to a lack of social supports. At the end of this project, we came away with 3 important lessons. The first is that continuity and coordination of care is paramount.
You're forced to switch providers at the most vulnerable time, lugging your baby on your backpack or however you do it. You don't know who your next doctor would be when you don't have insurance. You're talking about care coordination and risk stratification services that most managed care organizations are required to provide. So you lose that. Here you have a care coordinator who checks on you once a month, and suddenly there is nobody checking on you, nobody worried about your transportation, nobody, getting you to the doctor.
We also learned that coverage loss can further entrench economic hardship for mothers.
Like one of my moms they left a piece of placenta inside of her, and she bled out really bad. She ended up having to have surgery, but she still has health issues from that. She actually passed out again, and that was after the Medicaid hadn't got cut off. But it wasn't even her fault with the health issue. It was the hospital.
And then was she okay? Was she able to get
Yeah, she was able to get the help, but she had to pay. Her boyfriend had to, spend a little money.
We also learned that racism, bias, and inequality impact care.
Racism places people of disadvantage, and Black people specifically, into communities that then were disinvested, right? That compounded, right, over decades of time. And this disinvestment just led to more disinvestment, led to more poverty, led to no grocery stores, no just liquor stores, no playgrounds, no spaces to be outside, violence, right? Everything. It compounds on top of each other. And that's what created these social and economic factors that we see that play a direct role in the disproportionate prevalence and incidence of chronic disease, COVID-19, maternal mortality.
Moving forward, we recommend the following policy and programmatic actions. The first is that all states must expand Medicaid and extend postpartum coverage to at least 1 year. This coverage should include a comprehensive suite of services that are most needed by moms and their families, including lactation support, doula care, mental health care, family planning, preventive care, and other factors. In addition to the 1115 waiver process, states should also explore legislation and dedicated funding increases for Medicaid. We've heard about federal legislation mentioned earlier by Representative Underwood, and we also think that that is going to be essential. Passing federal legislation signed by the president that will help act as an accountability measure to have states do this. We also need to implement value-based care. This must go hand in hand with the Medicaid extension. We need to pay providers based on patient outcomes, and that means rewarding providers that help curb poor maternal health outcomes. We would test this by looking at success in terms of adhering to safety standards and also addressing bias and racism in the healthcare system and how it impacts the care that a patient receives. Patient-reported outcomes should be centered in this approach. We also need to increase Medicaid reimbursement rates to those at least comparable to commercial insurers. We heard from our interviewees that Medicaid rates are so low that some providers decide not to accept Medicaid patients. This leads to a lack of accessible care for women and families who need it the most. All patients must be valued, not stigmatized for the source of insurance that they have, and they must receive the highest quality care. Last but not least, we must address racism and bias in maternity care. While this project does not include a substantive study of the impact of racism and bias in the healthcare system, it came up consistently throughout our interviews. We must dismantle these issues, and if not, there's no way we can adequately address racial gaps in maternity care. We also need to systematically deconstruct how racism shows up in the healthcare system for people of color and ensure anti-racism training for medical students, as well as all healthcare personnel. To learn more, you can access our full report at tcf.org. And now I'd like to bring in our panel. We have Dr. Arvind Goyal, Amber Pendergraph-Leak, and Dr. Melissa Simon. You also heard their brilliant audio clips during my presentation. While we don't have time to go over their full bios in this moment, I encourage you all to read them on our website. This is truly a stellar group. So I am going to get things started with Amber. We're still waiting for Dr. Goyal to join us, and we'll get to him when he gets here. Amber, tell us about your organization, Birth Matters, and what you do as a doula.
So Birth Matters, we are community-based doulas here in Spartanburg, South Carolina. And we support families, moms particularly, 24 years and younger. We provide doula services at no cost to them. We actually visit them in their home to provide education, and then we're there for continuous labor support, and we follow mom and baby until baby is a year old, and we help them create a birthing plan. We also have a contract therapist for any mental health needs, and we're also CHWs, community health workers. So the liaison between the patient and the doctor for advocacy.
That's wonderful. What are some of the important needs new mothers have in the postpartum period?
So what I've noticed with the families that I've served is, of course, mental health. Where's the admin? Is mental health. They don't have the trusted providers. We need more providers that look like us. They also need support and, of course, ongoing medical insurance.
Mm-hmm. Thank you. And Amber, I want to continue with you a little bit. You know, when we talked to you for this project, you also shared with us that you lost coverage for Medicaid during the birth of your first child. Can you tell us a little bit more about that?
Yes, so with my first child, I can remember, and that was 13 years ago, but I can remember going into the doctor and I saw a resident. He was working at family medicine, and it was intimidating for me going in because I didn't know a lot about, you know, pregnancy, but I did have a lot of questions. And I noticed that he couldn't answer a lot of my questions. So then I switched to an OB, and I didn't know about all of my options. And part of that had to do with me, you know, just not educating myself. And I just depended on the medical staff I just felt like they had the experts and I was in good hands. So I really didn't advocate for myself. So I had my baby, and it had been ages since my aunts had children. So they were just like, you know, listen to the doctors. They know what they're talking about. So I went through like a traumatic birth because of, well, pregnancy. I lost my mom in the last month of my pregnancy. But I went to the hospital, had my baby. I didn't know that my Medicaid coverage was going to end within 2 months. So I went back to work quickly, but I was part-time. So there was like a lapse in coverage. So I didn't have medical insurance, but everything postpartum to me was fine. But moving forward, I had another baby 7 years later, and I had my own private insurance. And by now, I really knew how to advocate for myself. I knew how to navigate through the system. So I went to a respected OB office, and I just felt like I had the elite care. I knew a lot about what was going on with me, my baby. I was truly treated like a patient, like not just a number. They explained things to me. It was different tests that I didn't know about with my first pregnancy that I knew about with this baby. And I was like, oh my goodness, I was treated totally different. And so in the third trimester of my pregnancy, I developed a chronic illness. And after I delivered, I still had this chronic illness. And with my medical insurance, I was able to control this chronic illness that was so new to me. I was able to see my provider. I was able to manage it. But that's not the case for the families that I serve, because all of the families that I serve, they are Medicaid participants. And so after 2 months, if they have a chronic illness, it's dropped. So what are they to do? They have to scurry around to find another doctor to see what medicines they can afford. And that in itself, that can be very discouraging to someone that has a chronic illness or has a mental illness, postpartum depression. A lot of this plays factors. So that's where the CHWs come into place. And that's where we can navigate them through the system. And that's why I love the model that we replicate from Health Connect One, because we are true experts of lived experiences, and we know how to navigate through the system, and we can connect them with different organizations that can help. But it would be so much better for everyone if they did have medical insurance.
Absolutely. Thank you so much, Amber. And I think it was key there in you sort of sharing your testimony that, while you had a lapse after you lost your Medicaid coverage, and then once you had employment, you were able to get coverage, but you did have, about 3 months or so. Is that right? In terms of time between
Yes.
birth of your child when you lost coverage and then getting coverage. And so many moms that are impacted by this aren't as lucky as you are in terms of being able to have coverage, even if it's 3 months later. So thank you so much for sharing your story. I want to go to Dr. Goyle, who has joined us. And Dr. Goyle, you may have missed it, but during my presentation, I shared an audio clip from the conversations we had. We were conducting research for this project where you talked about how postpartum coverage loss impacts access to care as well as care coordination. What are some of the other challenges mothers face when losing Medicaid just 2 months after giving birth?
Thank you very kindly for asking me that question and giving me an opportunity to talk to people. Besides the inability to afford and the inability to access care with the provider that they've been receiving it during their pregnancy, during their labor, and the first 60 days, there is discontinuation of care for their normal issues that might occur in the postpartum period specifically, and due to pre-existing conditions such as blood pressure, such as heart condition, such as diabetes, they would lose coverage. There is also a specific issue with this opioid crisis going on. Think that even if a mother is able to give up tobacco use, alcohol use, or opioid use during pregnancy, of course, we don't recommend that they discontinue opioids during pregnancy. But if they do, then what you're looking at is the possibility, a significant increase in relapse rate, because their tolerance, physical tolerance may be the same, respiratory depression hasn't changed. They think they can still use the same dosage they were using before, and they get in trouble. As a matter of fact, maternal mortality from opioid overdose is significantly higher in the postpartum period. And then they're forced to switch providers at vulnerable time if they're able to afford it. They also lose some Medicaid-specific services, especially in states that are managed care states, such as risk stratification, care coordination, case management, and there's a loss of contraceptive benefits right after. You cannot access that. And to top it off, maternal mortality rate in the 1 year after delivery is significantly high.
Right. Thank you for that. And can you share more about how the extension is particularly important for moms of color and their health outcomes?
Can you clarify the question?
Well, basically,
go ahead.
Well, just the fact that, part of this conversation today, and there's been a lot of dialogue about extending postpartum Medicaid coverage, in the past couple of years. We've even heard about different bills that have been introduced by Representative Underwood earlier, as well as some other speakers. I think what's unique about what we're doing here today and the report that we produced is the fact that we are centering mothers of color in the conversation about the Medicaid extension. And so I'd love to hear from you if you have anything to share, offer in your experience in the state of Illinois. How do you see the coverage extension particularly beneficial for mothers of color and their health?
Recognize that the disparities are very, very obvious in the outcomes of pregnancy, delivery, as well as the neonatal survival and quality of life that comes with having a kid. We are very thankful to Century Foundation and yourself, Dr. Taylor, for raising this issue, because it is extremely important in Medicaid, where we have significant percentage of minority individuals under our care, if you will. And these people suffer the worst consequences. There are multiple reasons for it. I heard Amber at the tail end, and I felt sad that she had to go through this experience. This is not right. There are solutions, but I only am aware of long-term solutions on one hand, but I think we need to do better in the short term. And that would, to me, mean in the next year, the next 5 years, maybe next 10 years. But I think part of it is we need to educate our patient population, make sure they're aware of their rights, make sure they know their expectation, make sure they ask for what is right. It isn't important for us, in my opinion, that they go to a different colored provider, because we can demand the same care from whoever we go to and then follow up on it. If somebody says, I never saw my patient during the prenatal period, and the first time I saw the patient in labor, I think we have missed many opportunities. And those are the kinds of things that I would want to happen. I think we need to make sure as Medicaid that they have services available in their communities. We provide transportation when it's necessary. We take care of them and give them the best quality care, evidence-based, and that we assess their risk, provide them with whatever they need to have good outcomes. I hope I answered your question. If I didn't, I can talk forever.
Thank you, Dr. Goel. Yes, you did. And I think, how you describe those issues, particularly, I love how you pulled out the fact that, it shouldn't matter the color of the provider, right? Everyone should receive the highest quality care. All providers should be giving all of their patients the highest quality care. But unfortunately, we know that that's not currently happening. And I want to bring in Dr. Simon now, who I'm a huge fan of Dr. Simon. She's a physician and one of the country's leading experts on health equity. So Dr. Simon, I wanted to hear more from you on how the Medicaid coverage extension can help advance health equity.
Thank you so much, Dr. Taylor. That is way too generous of you, but thank you for having me here today with these distinguished guests, panelists. So this is about investing in people, in humans. We are all humans on this planet. And as we move forward through this pandemic, we've got to acknowledge that and build bridges, right? There's clearly a deep divide in this country, but right now, when we're talking about maternal health and well-being and really reversing these egregious disparities, we are the richest, wealthiest country on this planet. And we have the worst outcomes for Black moms versus white moms, and it's not getting better. So we've got to really rethink how we, inform and deliver health and health care. So this is about investing in our new moms and babies. Perinatal care is really a unique time. It's when, I'm an obstetrician, so when we get to see pregnant persons and birthing persons over 10 times in the period of 9 to 10 months. That is a lot of times you have to come to a healthcare provider in a very concentrated time. So you start to develop a unique relationship. And this is really important for the foundation of trust. And with the ability to extend Medicaid for all of the reasons that Dr. Goel noted, as well as Amber's experience that she so well articulated, we do a lot of work, but to cut it off so abruptly at 6 weeks or 42 days postpartum is egregious. It's terrible because there are so many things that have to be launched well when you have a new baby. And I'm a mom of 4, so I've launched 4 lives into this world. I'm still trying to launch them more, but it takes a lot of work to invest in that 1 year in your children and your new baby and in your body and your health. So having access to continuity of care is required. I mean, we all know it, regardless of our socioeconomic position, that access and that ongoing support is critical. We have never, like you said, about centering Black women in our care, we have never created perinatal care that was centered actually on Black women and women of color. And although there are some alternate models of perinatal care, far and wide, American women actually receive routine traditional perinatal care. And this model has never been revamped outside of, group prenatal care. Obviously, there's a wonderful midwifery care, there's doula support, et cetera. But the actual just routine standard obstetric or perinatal care delivery has never been revised. And that's what my team's working on right now, actually. Can we redesign just a little bit the checklist that's required? How do we establish trust with patients? How do we do a better job of centering that care on Black women and women of color in this country? And then just a couple other things. Safety that hasn't been brought up is really important with the postpartum 1 year period, including intimate partner violence. That still is high during that postpartum period. It's high during pregnancy. Being able to check in on diet and physical activity. We know that nutrition and physical activity are super important because gestational weight gain, how much pounds you gain during pregnancy, and then weight retention. So the amount of weight you still keep on postpartum, and then entering into another pregnancy already with extra poundage on your body can compound and other comorbid conditions, can make you less healthy going into the next pregnancy. So that year postpartum is really important as well to check in on physical activity and nutrition. So all of those things are really important. And what we really want to do is move women from just surviving to thriving. And that year postpartum helps women thrive if we can best support them in the healthcare system.
Thank you, Dr. Simon. I want to shift and talk a little bit about racism in the healthcare system. In the clip that we shared earlier from you, you talk about the societal manifestations of racism and how they're directly linked to the onset of chronic illness and maternal mortality for Black women. How does racism play a role in the healthcare a woman of color receives? This is for you, Dr. Simon. Yes.
Okay. Just making sure. So racism, it's deeply embedded into our country, into our society, unfortunately, over centuries, right? With even the godfather of modern gynecology, Dr. Marion Sims, performed egregious amounts, dozens of operations on unanesthetized slaves against their will. And we need to acknowledge that. We need to acknowledge that women, Puerto Rican women in the 1950s were experimented on without their knowledge around the modern birth control pill trials. And then in the 1970s, women of color were forced to be sterilized. Indigenous women, Mexican and Puerto Rican women, women of color. And then even now in 2020, there were forced hysterectomies in immigration detention centers. So this is where we're at. We're at this history that is really needing to be acknowledged so that we can actually pivot and move forward, right? We also have to confront like I said in my quote, the decades of disinvestment in communities, of racist policies such as Jim Crow that have, segregated people that have had stores and grocery stores and all these other resources that are important to help people achieve and maintain health they're just not there in some communities versus others. So this along with the experience, the personal, familial, friend, community level experience of racism and discrimination in the healthcare system. So when women of color, especially Black women, go and try to access care, they're not just accessing it with the experience of personal racism within the care system themselves, but they also carry that knowledge that their brothers, their sisters, their mothers, their friends, their community with a large C, capital C, have experienced discrimination and racism. So we as healthcare providers have earned distrust of women of color when they enter into our health system, and especially Black women. So we've got to work a lot harder to earn trust back. All right, and we can't use that distrust or mistrust that some people call it as an excuse for patients not engaging in care. The onus is on us as a healthcare system and a team of healthcare providers to make the experience better. And we've got to work really hard to do that. And so racism is real, and no level of implicit bias training or critical race theory training is going to do it. We've got to work actively at it every single time to make sure and ensure people like Amber receive care that's high quality, consistent, and also they experience and receive the care themselves as being fair, and that people are listening to them and not just judging them based on the color of their skin.
Mm-hmm. Thank you, Dr. Simon. And so my next question is another follow-up on this, and this is for both you and Dr. Goyal. What advice do you give to your colleagues, particularly other physicians and nurses, when it comes to dismantling racism in the healthcare system?
Do you want to go first, Dr. Goyal?
You're on mute, Dr. Goyal.
I can go if you want me to.
Dr. Goyal, you're on mute. Melissa, why don't you start?
I'm going to start. So first and foremost, this is a marathon. This is not something where we in the healthcare system, my colleagues, my leaders, et cetera, say, okay, we're going to make everyone take implicit bias training and that's it. Or we've hired a chief diversity officer or some people of color and that will just make everything go away. That is completely not the case. This is a long game we have got to enter into, marathon. There's going to be some sprints because there's some things that we got to do right now to make some quick fixes. All right. But from there, we must acknowledge that really being anti-racist in our approaches to healthcare delivery and anti-racist in our institutions and clinics, the big health systems, we really have to play the long game and really look introspectively. What are our policies? Who are we hiring? What does the team look like? Where do they come from? Are we really hiring from communities themselves? How are we keeping people on the team and keeping people happy? How are we actually delivering care? Is it consistent regardless of all the clinics we have? Do we really look at our data and say, yes, we are providing consistent quality of care across every single pregnant person and birthing person and postpartum person across the entire footprint of our institution or system. And so we really have to look at every single layer that impacts the end delivery, the care delivery at the end user, and really ensure that we are doing this in a truly anti-racist, pro-social justice and health equity approach. And it's got to be every single place. And there's just not going to be one quick fix or panacea. And it really is the long game, the marathon.
Thank you. Dr. Goyle?
Yes, I think I was on mute accidentally. Thank you for accommodating that. So I have a favorite sentence that I used to tell my students, and I still teach at one of the medical schools periodically. The sentence is that in healthcare, you need to worry about producing good quality of care, good quality metrics, but it helps to be colorblind. Same thing that my wife has accused me forever. You're colorblind. You can't tell green versus orange versus anything else. The point I'm trying to make is for every patient you treat, you've got to be at your best. You've got to produce the best results. And I think we need better metrics to be able to determine that your care was indeed consistent with best practices. I think it starts with educating our communities, with our medical students, our residents, and in our practices to be sure that our teams live up to that expectation. It's a minimum we can expect.
Right. Thank you. And the next question is really for everyone to chime in on. And it's focused on community-based organizations. And these are usually the first responders for women and families at the community level. They're first to be there to respond to the healthcare needs of these families, as well as their social supports, which is really critical for their health and well-being. What role can community organizations, as well as community health workers, play in ensuring that the postpartum coverage extension is implemented in a meaningful way for women and families? And why don't we start with Amber?
So we can speak to their true need, to elevate their voices. We can bridge the gap. We can help bridge the gap. I'm an expert of lived experiences. So just elevating the voices, listening to them as well.
Great, thank you, Amber. Dr. Goyle or Dr. Simon, did you have anything to add on this?
Yeah, I think Amber said it well. Amber, people like Amber and community organizations that I partner with all the time, locally and across the country, they are the voice and the direct bridge to pregnant and birthing persons and postpartum persons. It's critical. I mean, as much as I'm from La Comunidad and community and El Barrio in Detroit, of course, I have community connection, but the further I go up in my fancy Northwestern near Neiman Marcus kind of place, the more disconnected I get, even when I try really hard to be at that ground level. And Amber and many others across the country are working relentlessly, tirelessly to really keep that bridge up and be the voice. And we as healthcare providers, scientists, practitioners, need to really listen and figure out what do we got to do to pivot, policymakers as well. And I love Congresswoman Lauren Underwood and her team and others, because the Momnibus represents that listening, and that it's a really nice example of listening and hearing all of the stakeholders, what we all need across every single stakeholder, and weighing in and to create policy that could really make substantial impact in these disparities that are happening. So community organizations and community health workers and doulas and midwives play essential roles. There's just one other thing that I'd like to see happen better though. Right now, community organizations, doulas, midwives, other birthing partners are parallel often to the healthcare team. They work in parallel as opposed to like this. And we need to do more of this. We call it a team. I use the word team all the time. I've used it probably 50 times in this panel. But really make it a team. Like, there's one thing to say you're a team, but to really make it a team. Like, when oftentimes doula care is done on the side, away from the obstetric or the perinatal care in the clinic. And so we as clinicians don't get to see the doula until the labor floor. And so is there a way to kind of change that and be better more thoughtful about integrating that? I think we can. So we got to think about how to do that better.
So a point very well made, Dr. Simon. I would add to what you said. I think the advocacy role of the community organizations needs to be a little more forceful. They need to be there for the population that they're representing and make sure that they get the services they're entitled to. Even in Medicaid, where the services isn't necessarily an issue, I think they deserve to be cared for. But anytime there is a flaw, anytime there is a deficiency in the care they receive, I think they need to take it on. They have mechanisms to address it. And I do believe that for that particular role, the community organizations need to be based in the community.
I think oftentimes they are based in the community, and of course it's going to be different based on whatever the situation is on the ground in a given state. I'll just add, in my experience, community-based organizations and community health workers, birth workers, they're the fiercest advocates when it comes to their patients and centering them and advocating for compassionate, supportive care, even in the context of the care that these patients are receiving in clinical settings. And then they're also, as I mentioned earlier, helping to connect patients with the social supports that they also need. So thank you for that.
There's one more thing I want to bring up, because I understand where Dr. Goyal is coming from in his notice of color blindness, but that's not what's going to help the anti-racism and health equity social justice approach. And we actually can't use the colorblind perspective. And I think this is where community organizations, doulas, birthing support partners, and people are really critical, because it is important for us to acknowledge everybody's racial, ethnic, gender identity, all of our differences. And instead of being blind to that, or a so-called blind approach, I think what Dr. Goyal is trying to say, I believe, and I don't want to speak for you, is that we need to partner with community organizations and people like Amber, et cetera, who can really help us connect and better understand, and therefore deliver more empathic and trustworthy care by acknowledging who a person is, what is their background, what's their context, where are they from, what color are they, what is their ethnicity, what is their religion, what are their beliefs, and really slow down some of that parts of conversation within the healthcare delivery visits for perinatal care, so that we can earn trust, so we can listen and learn and earn trust. And I think that's really why this integration of community organizations, doulas, birthing partners, and people like Amber are essential to people like me who are on the ground caring for pregnant and birthing and postpartum persons. And it's essential. So we can't be colorblind. We have to deliver quality of care no matter who they are, but we really have to acknowledge who this person is, because this person is not just, a Black woman, for example. This person could be, a mixture, a wonderful amalgamation of so many different richnesses, ethnicities, cultures, religions, backgrounds, experiences, and we have to acknowledge each person for who they are. I hope that helps.
And I would certainly respond, Dr. Simon. I cannot disagree with how you explained it. And absolutely, that is the ideal we want to achieve, where you're aware of the differences, where you practice with those differences in mind and make your care consistent with a person's origin, whatever that might be. The point I would make to you is that I was trained at Cook County Hospital, which is a public hospital. I never knew the difference when I was doing 30 deliveries a night in my labor and delivery. And I'm a family practitioner. I'm not an OB-GYN. I would say to you that the farthest thing from my mind those nights when you have to do 30 in a 13, 14-hour period is what color the individual is. You're doing deliveries. You're doing your best. You're reporting, you're making a rapport with the patient. You're continuing to follow them postpartum. And I would say to you that we have equity training, we have cultural sensitivity training, we even have language training, some of it mandated by the state now. And the point I'm making to you is that to transform the whole system is certainly an achievable goal. However, as a beginner, for the starters, we need to be sure that person of every color receives a similar high quality care from every provider of different color. And that's what I needed to say.
Yes, and you both are essentially saying the same thing, just in different words per se. But thank you so much, Dr. Goyle, for explaining that. I do want to get to at least one more question before we get to audience Q&A, and I know folks are holding on, and there are lots of questions coming up. But we can't end this portion of the conversation without talking about COVID-19. We're still in the midst of a global pandemic where we've seen a recent uptick in COVID-19 cases and deaths. And not too long ago, the CDC released a report that showed that Black and Hispanic pregnant women are most at risk for complications due to COVID-19, including preterm birth. How has COVID-19 impacted your patients or the work that you do to support pregnant women and mothers? And this is for all of the panelists. Why don't we start with Amber?
Hey, so it has changed in many ways. I do home visitation. So in a typical setting, I will go out to the homes and educate the moms, talk about what's going on with them, the baby, help create a birthing plan. So now we've adapted to doing virtual visits, and not everyone has access to the internet. So sometimes we have to do phone visits. So some people are more you know, if they see it, they get it with the education, because we are really wanting them to advocate for themselves. So we really have to like show them how their cervix dilates and different things like that to even help them prepare for the birth. So initially when COVID first began, it was just one support person. And most of the time they're going to pick their partner. So we had to attend birth virtually. So we worked really hard with our hospital here in our county. So now just this month, we were able to attend the birth. But in the beginning, from April until November, we had to do that virtually. And for a mom who has a birthing plan and her support person, her doula that she wants there, her additional support person, you know, we can't be there. So, and in the hospital, everyone's wearing masks, everything is different. It's not the norm. So it's like, you know what, I'm getting so anxious. Like they said, I can only stay a day. So if I don't do the birth the way I want to do it, I have to do it this way. So it's kind of like they don't really matter. And we're having to FaceTime them. And we're not physically there. And they are so grateful and thankful. My families, the families that we serve, they're so grateful and thankful that we're still there with them, but it's just not the same. And I will share about one of my moms. She knew from the beginning, Amber, I want a natural birth. I want a natural birth, unmedicated birth. This is what I want. My body is capable. I'm able. I can do this. So I went to the birth virtually. We talked and her mom was tired. And prenatally, we discussed that, you know, your partner, we would like for them to be well rested, but we don't know when baby's gonna come. So her baby actually came a week early. Mom got off of work. Mom was there to support her. Mom was tired, so she couldn't offer a lot of support. And a lot of things were starting to trickle. And she's like, you know, Amber, I'm just over it. Like nothing is going my way, and I just want this to be over. So, and the doctors are pushing me, you know, to get this epidural. And she just really felt defeated. And so she ended up getting a medicated birth. But it was still, you know, healthy mom, healthy baby. So it was still a beautiful birth. But she just felt like a lot of odds were against her. But I've had some beautiful natural births during COVID. So we have adjusted. We had to adjust. So it's beauty in it all. It has been adjustments. So that's how that's worked out for us.
Thank you so much, Amber. Dr. Simon or Dr. Goyle, did you have anything to add on this one?
I want to say, if I may, Dr. Taylor, that as you know, we have our application for 1 year postpartum coverage pending with the CMS.
Mm-hmm. Yes.
However, due to COVID-19, there is a maintenance of coverage clause, which allows us to continue coverage during this pandemic emergency until the end of the emergency. We are hopeful that our waiver will be approved prior to the end of the emergency. But for the time being, this is an advantage to our population that except for undocumented women, they can continue their postpartum coverage with the same stipulations until the end of the emergency. I just wanted to put that on the table.
Yes, thank you so much for making our audience aware of that. This is absolutely true. Dr. Simon, did you want to add?
I think the intersection of two pandemics, the pandemic of COVID-19 and racism, has really unearthed the health inequities and how deeply ingrained they are to people who haven't seen it before. And so I think we're at the precipice of a really important opportunity to figure out how to move forward. What did we have to do to pivot, like with the telemedicine visits with trying to articulate our evolving hospital policies that are again going to get stricter again because even in Chicago, our case rates going way up off the roof, and we're on lockdown again, pretty much stay-at-home order. I'm not going to call it lockdown, but we're a stay-at-home order now starting today from our mayor. And so it's really important that this flexibility and how we learn to better articulate that to pregnant and birthing and postpartum people, it's really important, and to the public in general. So this is a real unique opportunity to figure out, does telemedicine, telehealth approaches work for perinatal care and postpartum care? Do they work for intimate partner violence and mental health screenings and care delivery? Do they work for blah, 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 like all these different things? And indeed, I think we may find that we're going to end up after this pandemic doing both, some kind of hybrid of in-person and either telephone or video visits, and learn, and then also learn how to articulate emergency things in emergency and the changing policies that happen sometimes on a daily basis to the public in a better way so that we can engender more trust.
So there is a good reason, Dr. Simon, we call it a syndemic, because add to those two epidemics and pandemic that you mentioned, add to that the opioid epidemic, the opioid overdose and death epidemic. It's a true syndemic. I think we really need an attack on these issues that works in different directions.
Thank you all so much. So now I want to move on to audience Q&A. We have quite a bit, and I want to try to get to as much as we can with a limited amount of time left. The first question is about undocumented immigrants. And so just wanted to ask for you all, what options does this population have to access care in the postpartum period?
For the community in which I serve, we have an organization that actually helps with undocumented people that need help prenatally and postpartum. It's called Access Health in Spartanburg.
That's great. What about in Illinois? Are there coverage options available for this population?
I can answer from Medicaid perspective. A woman who's pregnant gets a presumptive eligibility for coverage during pregnancy and 60 days. However, because of the federal rules, our application for 1-year extension does not include undocumented women, and that is unfortunate.
Yeah, it is unfortunate. And then I'll also add to, there's, advocates. This is another area that advocates continue to focus on in terms of ensuring access to healthcare coverage, health insurance coverage for the undocumented population. And some states have made changes in terms of allowing these populations to have coverage. I think California, if I'm not mistaken, has a model where they're offering coverage for this population. So there are some states that are more progressive on this than others.
I do not believe so. And the reason I say that to you is we are one of the 3 states who have expressed publicly they're interested in expanding postpartum coverage to 1 year. So pregnancy, delivery, and the 60-day care, progressive states do as well as we do. But beyond that, nobody does it right now.
Okay. I was referring to general healthcare coverage in the state of California. They did recently make changes to cover immigrants in their coverage. But yes, you're right in terms of the specifics around the postpartum coverage issue. Okay, the next question is about community-based organizations, particularly doulas. How do you believe that community-based doulas, lactation counselors, Maternal child health, community health workers can provide education and support on COVID-19, namely safety, testing, vaccination, et cetera. Dr. Simon or Dr. Goyle or Amber?
I think, again, like I said earlier, I think community organizations and on the ground persons like Amber are essential to building important health education messages that are founded in trust. I think right now, because we do not have a strong national message around COVID-19 safety and approaches, it's really, really important that message tailoring is hyper local, spread through trusted organizations. So for instance, through Black churches or through Latinx community organizations or tribal organizations, things like that, that are hyper local, that can bridge that trust. Because right now, as the vaccines, because we now know, 2 companies have vaccines that have a very wonderful high efficacy rate. We really need to figure out how to get the message out, not only of continued masking and social distancing and hand washing, but how we get that vaccine for COVID is going to be crucial, because maybe around March, April-ish, that this vaccine is going to get availed to the public, or at least different parts of the public as we move forward, depending on the strategy after the healthcare workers and frontline workers receive the vaccines. So this is going to be really critical. So Amber, you and everyone else who plays roles in their communities like you are super essential to really getting us out of this pandemic and moving us all forward. And I think.
And I ditto everything that was said.
Great, thank you. The next question is about the interconnection between parent and child health. And so the question is, given what we know about this interconnection, what opportunities do you see in Medicaid to more effectively align initiatives for pregnant women and their children?
So if I can clarify the question is care of pregnant women that would improve children's outcomes. Am I getting it correct?
Yes, and how they both are interconnected. Healthy mom means healthy baby. And so what can—
Absolutely.
Yes.
Now I understand. So understand that mother, if she's not healthy, you can't expect the baby to be healthy.
Mm-hmm.
She's keeping the baby in for 9 months. You can't even see him.
Mm-hmm.
And so everything you do to help the mother can be translated into help improve the health of the baby.
Mm-hmm.
Now, it is possible occasionally when the mother isn't doing well, the baby could still be healthy. But the reverse is more likely.
Mm-hmm.
If the mother isn't doing well, the chance of a baby being healthy is less. And I can talk to you all day long about the conditions, starting with alcohol, with tobacco, with opioids, with nutrition, with anemias, with heart conditions, anything you want to talk about. It can have an adverse effect on the health of the newborn baby and subsequently.
Yeah, I just want to emphasize what Dr. Goyle said. When we're on airplanes and the oxygen comes down, what do the flight attendants always say? Put your mask on first and then secure it for your loved one or your baby, etc. It's important. We have to take care of ourselves. Self-care is actually an important thing that is completely discounted, especially amongst Black women and Black birthing persons, pregnant persons, postpartum persons. And it is so essential, especially right now, because in COVID, with homeschooling and all of this other stuff that's going on, self-care has gone out the window. And so we got to bring that back. And part of self-care is extending the care that we give, the healthcare coverage, to postpartum persons for that entire year. It's super critical because what we do as healthcare providers is help launch and support and provide referrals and resources and advice and education around a myriad of important things related to health, including substance use and safety and intimate partner violence and blood pressure and sugar and physical activity. I could go on and on, contraception, all of those things. We serve as the hub for that education and in partnership with doulas and in partnership with community organizations. But if we get that year opportunity, that 1 year post-birth opportunity, what an amazing opportunity that is to be able to actualize and operationalize, to actually launch not only mom, but launch baby off to an amazing start. And that's what it comes down to. We're investing in our communities for the future. These are the future, these little babies that are coming out. This is the future. And the moms are at the helm of that ship, steering the future. That's why we got to do this.
Absolutely. Amber,
Yeah,
you want to add?
I agree with both of the doctors, but it's the doula lens coming in. I'm definitely going to say bonding, breastfeeding, skin to skin, in conjunction to what they're saying, the doctors.
Yeah, I'll also just add too that I've also heard that pediatricians, when moms come in to bring their babies for their checkups, some pediatricians will ask mom about how she's doing, particularly centering her mental health. Keeping in mind the fact that sometimes as moms, as has already been mentioned, that we forget about our own health. I'm a mom as well, and tend to center my universe around my son, sometimes to the point where I'm not taking care of my own mental health and well-being. And so I think that is also a promising approach to making sure that moms have the support that they need, and then also something that's coming in at the intersection of both the health of mom and baby. The next question is focused on, and I think this will probably be the last one that we'll be able to get to today. This one is focused on beyond expanding Medicaid to 1 year postpartum, what are some of the most immediate steps we can take to curb the high mortality rates among Black mothers? Amber, you're on mute. I see you talking.
Okay, so could you repeat the question, please?
Sure. Beyond expanding Medicaid to 1 year postpartum, what are some of the most important and immediate steps we can take to curb the high maternal mortality rates among Black mothers?
I'm definitely going to say emotional support, having more providers that look like them, trusted providers, and ongoing mental health.
We have to listen. We healthcare team members, we have to listen to everybody, including, imagine that, the patient. And really figuring out what the heck does it mean to center care on that patient, on that pregnant and birthing person and postpartum person, and especially for Black women, for sure, because we've done not a good job of it so far. And so we have a lot of opportunity to move forward in a much better way. And so it starts with listening and realizing, acknowledging that we have earned distrust, and we've got to work hard to eradicate that distrust and build trust, and that every person is unique, and we've got to listen to who they are and what their needs are. Imagine if obstetrics providers like myself actually stop and have a trust visit before we have the first perinatal visit be a trust visit, and we just sit down and ask. So what are your expectations during this pregnancy? What do you think are going to be your biggest challenges during this pregnancy and postpartum? What can I do to help you get through this? Because we're a team, and a true team, and we got to start working that way.
If I can add, I think one of the two pieces that haven't yet come up in this discussion, one is we need to really make sure that all women who are pregnant or potentially planning a pregnancy need to be told, need to be educated that they have to go to their healthcare providers as early as possible. Because if they don't show up for prenatal care, prenatal evaluation, there are few opportunities to influence the outcome of that particular pregnancy. And then the second thing is that their basic needs, the social determinants we talk about, they need to be supported on housing, food, whatever else they need for their care, I think is a basic minimum. You cannot leave a pregnant woman out in the cold on a cold day.
Right, absolutely. So we mentioned social supports earlier, and that's exactly what Dr. Goyle is talking about. You know, access to housing, nutrition, these other issues are also very essential to, you know, the health of a mom and her pregnancy as a whole. So thank you for that.
Yes.
Okay, well, that essentially is going to have to wrap up the event for today. And there are lots of questions that we didn't get to, so I apologize to our participants for that. We will certainly collect them and keep those in mind, and maybe even have an opportunity to respond to folks through another opportunity. Thank you so much for attending. I also want to send a huge thank you to First Lady of New Jersey, Tammy Murphy, Representative Lauren Underwood, Dr. Goyle, Dr. Simon, Amber, and the teams of the Commonwealth Fund and the Century Foundation. A recording of this event will be made available immediately afterwards, and you can also go to tcf.org to access it there. You can also access our full report, which we talked about at length earlier, and get more information on TCF events.
Thank you.